come to order. And why don't I go ahead and bring up the first, or I guess we should call the roll. So clerk, please call the roll.
Delegate Watts,
Present.
Delegate Hope,
Present.
Delegate Price,
Here.
Delegate Willett,
Here.
Delegate Bell, Delegate Austin,
Present.
Delegate Brewer,
Present.
Senator Hanger, Senator Barker, Senator Favola,
Here.
Senator Mason,
Here.
Senator Deeds. Mr. Co-Chair, we have a quorum.
All right, thank you, Mr. Clerk. So why don't we call up then the first presentation from the Department of Behavioral Health on the bed crisis, and who do we have here for?
And that one will be virtual presentation.
Virtual presentation. Is that you, Commissioner?
It is. It's Allison Land here from BBHDS, and
Welcome.
Josie. Hi, Josie Mace is going to be pulling up my slide deck and advancing my slides for me. I think they're coming up now.
Very good. We got them up. Welcome.
Okay. Hold on just 1 minute. Okay. Well, good afternoon, members of the Behavioral Health Commission. Thank you for inviting me to present today. What I'm going to talk about, so Josie, next slide. I'll be focusing on 3 timely and critical topics today, and I believe that there are some members present here who were also at the HWI presentation that I made, and so I hope that it's okay, but some of this will be going over it twice for some of you. The first, of course, is the bed census crisis, and I'm very pleased that we've been able to reopen the remaining hospitals, which were temporarily closed to admissions. And then I'm also very excited to announce today that we will be able to open an additional 14 beds at Catawba Hospital this Friday, the 24th, and an additional 7 beds at Central State Hospital next Wednesday, the 29th. So we were able to reopen to limited admission. So as we discharged a patient, bringing one in, but these hospitals will incrementally increase the number of beds that they have open. And we'll share more about what those numbers look like in future slides. And then the second topic is also critical to addressing the census crisis. Our crisis transformation efforts are also going to be ongoing. And our ARPA dollars that we received will significantly boost the availability and comprehensiveness of these services. And then finally, we will review the current status of substance use disorder services and how the new ARPA funding is helping to grow those services as well across Virginia. So, but first, next slide, Josie. Actually, go to, we're going to be starting with the bed census issue. And as you were aware, back on July 9th, we did close 5 of the 8 adult state hospitals to civil TDO admissions temporarily because of critically low staffing levels and dangerous conditions for both the patients and staff alike. We've been working intensely with all of these hospitals to facilitate safe discharges and consolidate the staff so that we could have safer staffing levels and a safer environment for patients and staff. As we were doing that, we never stopped taking forensic patients as there are no private options for those individuals. And we were able to reduce the census levels, and the number of injuries to patient and staff have declined, and the staff to patient ratios have been improved to the level we were able to reopen. We did have to use all of our emergency reserve funds to procure additional contract staffing from out of state and for a first quarter of direct care staff recruitment and retention bonuses. So we were very grateful also in the special session that we were able to be approved for ARPA funds to extend those bonuses for the next 3 quarters to the end of the fiscal year. So Catawba Hospital was the first to reopen after a 2-week closure. Then we had Western State and Piedmont Geriatric Hospitals reopened in mid-August. And then earlier this month, Southern Virginia Mental Health Institute, Central State, and Eastern State Hospital, all 3 reopened as well. As I said, they reopened on a limited basis, operating on a 1 discharge to 1 admission basis for civil patients, and we're continuing to work to increase our workforce. And as I mentioned, we're going to plan to incrementally increase available beds as the workforce improves. So these first 2 that are going to have this week and next week having incremental increases. We're watching them all closely, and just as soon as we're able to safely do it, we will incrementally continue to reopen until we reach back to 100% capacity. Again, it's Catawba and Central State are going to be able to do those additional beds. And while you'll see on the next couple of slides that our staffing is not perfect, we did not try to reach perfection. We just needed it safer. And so we were able to open, and we'll continue to carefully monitor that. But also especially Northern Virginia Mental Health Institute and Southwest Virginia Mental Health Institute, both stayed fully open and operating at 100% capacity, even with their staffing shortages. So we're watching them real closely so that they don't start to see that mass exodus of staff that then makes it get less safe for them as well. So we're keeping a close eye on everything. But I think that it was not just a DBHDS effort that's allowed us to get to this better position. It was really working with all of our stakeholders. The community services boards worked with our staff to facilitate safe discharges. We had our facility staff increased already aggressive recruitment and retention efforts, as I mentioned. Many of the private facilities developed and opened step-down beds for state patients or for diversion to their facilities. And we know that law enforcement has been called on to work extremely hard to ensure safety of patients who were under TDOs as they waited at times for hours and days for an available bed to come open, whether that was at a private or state facility. And then finally, again, we're just very appreciative of the ARPA dollars for the state hospital direct care staff bonuses and other efforts to reduce the state hospital census, which are really, really and truly critical to alleviating this crisis. Next slide, Josie. Did we miss one of those? Is there one ahead of that one? I think I had a slide that was showing the picture of the bed census. Oh, there it is. Okay. This slide provides a quick update on the status of the bed census at each of those 8 adult hospitals. And it's important to note that the ability to discharge enough patients to be able to consolidate staffing to achieve the staff to patient ratios that were safer, you'll see that collectively that meant discharging 248 patients. So that's where that 248 unstaffed beds are. And it also clarifies that those are the beds that are currently offline. It shows the normal capacity of the hospitals in the total bed column. And as you've seen before, but it also shows you how many of those beds are currently open, and that's in the staffed bed column. And then, of course, doing the math, the unstaffed are the ones that we discharge and are still left open without staff. And so they're really closed during the staffing crisis. And then they're all now open on at least a limited basis. You can see that our total census and utilization remains high, though those temporary closures have resulted in utilization under 100%, of course. This is a snapshot in time, and these censuses fluctuate daily. So you see people being admitted and discharging throughout the days. And so we see times when the hospitals are all operating at 100% of their staff capacity. So sometime throughout the day or multiple times per day, they're at 100% as we bring them in and are able to discharge them out. Also, you'll see in the next slide that the bed utilization noted here does not fully relieve the desperately low staffing levels. So just because we're at typically around 70% or higher of utilization in these facilities, you'll see that that does not equate to always us having 70% of staffing. So next slide, please. Okay, so since April of this year, vacancies have increased more than 50% from just over 1,000 to 1,600 today. And that's out of a total of approximately 5,500 staff across our state facilities. And several of our state hospitals are operating with direct care staffing levels you can see as low as 45%. So if you remember, again, on that previous slide, when we're operating typically at 70% or higher, these are really continuing with very low staffing levels. But we were able to get to a better level of safety, and which is why we opened. And I did promise that I would open as soon as possible. I wasn't going to wait till it was perfect staffing. I think that everybody realizes how the pandemic drove many workers to positions that pose less risk to them, both to their personal health and well-being, as well as having to work in facilities at the level of dangerousness that they were experiencing in our facilities with extremely low compensation. And I think that's really what tipped us into the staffing crisis. And fortunately, the new funding is already demonstrating some relief to our staffing situation in order to ramp up capacity as quickly as possible and to ensure a safe environment for patients and staff. So I'm going to share some of that data with you next. Next slide, please, Josie.
Commissioner Land, can I ask a couple of questions?
Sure.
Am I to assume that in the next budget that there will be a plan for continued funding for increased pay for staff so we don't have another crisis, no matter what the future may hold with this virus or whatever the next crisis is?
Yeah.
And also, I mean, I'm afraid that in many respects, we just push the problem down when we close the hospitals to law enforcement and CSBs. And what I'm hearing from a lot of the CSBs that contact me is that some of the pay issues affect them too. Do we have a holistic approach to paying people at the local level or finding a way to increase pay there, increase staffing?
Yeah. So we will be doing workforce development, putting in proposals for that, and really a pipeline for all of the system, not just our facilities, and that will be, put forward. We're working closely with the Claude Moore Foundation, and Deloitte is working with us on what that plan would look like. So we're hopeful to be able to bring that forward this year. We also, yes to the commitment that the governor made to put this funding in our base budget going forward at the time that the ARPA dollars were approved. And then I know that our stakeholders are also being looked at, and proposals are being put together for them to have staffing proposals as well for new compensation levels and retention and recruitment bonuses. I think also for, I don't know if it's just corrections or if it's if any of the law enforcement, I think they are also putting forward proposals. And we, of course, are going to be hopeful that other proposals like what we've talked about before with this group and in the law enforcement, getting that transfer of custody as we talked through things last year and over the summer this year. Hopeful to bring some of those things back forward. So all of those things we're hoping to push together so that we really get all of the stakeholders and the staffing, because workforce is one of our biggest issues.
It's a huge issue, and I'm just hoping that we can eventually get to the place where we have an approach that recognizes that we have a system, and that
Right.
includes the CSBs and the hospitals, and we've got to take care of our employees to make sure we have employees at every one of our facilities.
I agree totally.
Thank you, ma'am.
So this is a slide that's going to, our serious injuries to staff have been, one of our biggest concerning factors, and one of the main reasons that we were losing staff in addition to the low compensation levels. All of these required medical attention, and many required hospitalization for these numbers that you see here. And you can see that we've had a decline. And we continue to see spikes, like this slide really shows that, but it's become far more manageable and safe. And then you'll see there's a corresponding decrease in injuries to these state hospitals as the hospitals become safer, and their staffing levels are what makes it become safer. Next slide, please. This slide is a little busy, but I know we were asked some questions at HWI to kind of really talk through what we were seeing from the vacancy rates and things at our facilities. And so you can see on each of these that the blue line is the actual vacancy, but we've actually been able, like I mentioned, to hire some contract staffing to come in and buttress us. And so the red line is what the vacancy rate is with the contract staffing. So really having that ability to bring those in as we're getting the classified employees brought on board But at some point, the contract staffing are going to have to leave. So what we have to do is make sure that we are, by the time we get there, then we have the classified staff in place. And so that's why we're being very careful and we're recruiting so heavily. And so you can see it's across our direct care associates, our LPNs, and our RNs are all seeing reductions in the vacancies. So we're seeing some good results there. The next slide, Josie. And I also wanted you to see kind of an idea of the sense of the improvements that we're seeing in separations and new hires. So you can see in the lighter green in the background, that's the contract workers where we brought on that bolus of out of state contract workers. And so they came on a little bit slowly, and we're still getting some coming on. So we have about, I think, 50 more of them coming on. They're for 13 weeks each. So it's kind of it's not everybody 13 weeks will end at the same time because some haven't even started. So we'll continue to have contract staff as we're bringing those classifieds on. And then you can see the green bars are the classified hires. So you can see those spikes. Those are when our main orientation weeks are, or when these hire bars are. You can see that's increasing over time. And then the separations are the red, and you can see as a trend, that's going down. We're still seeing, 1 to 2 per week at each facility, but it's down from considerably more.
Mr. Chairman.
Next slide, please.
A question, please.
Sure.
Thank you. I'm just curious, do you have any data that suggests there should be changes in the workplace that might also be welcomed by employees and perhaps effective in keeping employees retained in addition to higher pay? I mean, there's some, the work quality of the workplace, I guess.
Right. So I think that the biggest part is the dangerousness, but also we're working within a staffing model that has been funded and set up that was for a chronic population. So staying long-term chronic in the state facilities, which was more like I would call a nursing home level of care over time. I mean, they were truly acute, and our forensic units, of course, are different. But when you change your population, like what happened with our bed of last resort, and now we get almost 2/3 of our patients, or just at 2/3 of our patient, are short-term acute. It's a very different population and requires a different staffing model. And so we actually, while we're trying to, it will be a blessing in each of these facilities to get this 1,600 direct care vacancies filled, which I think, we're on the move, and we're getting the solutions to do that, and it will become so much safer, but it will not truly be at the staffing model that is needed to manage this type of patient and to really get the quality and the outcomes and build that pride in the work from getting those outcomes and having that higher level of quality, which I really think it takes to have engaged and employees. And so I think we're still going to have some issues, but it's really been being well received that we've heard them and we're doing something about it currently, is what I would say to that. But we will still have issues. All organizations have issues.
Thank you.
Okay. So one of the things that we were asked was to share some of the new funds that we received in the special session from the ARPA funding. And so we've already talked about it, but those allocated bonuses for the direct care staff was $45 million for those next 3 quarters. And then the governor's intention to fund the full $76.9 million for salary adjustments into the base budget, starting in FY23's budget, so this coming up budget. And then the ARPA funds were also received that can expand the pilot programs for individuals with dementia who are ready for discharge and need nursing care. And that was $1.65 million from ARPA this year. And then also the governor's also put forward a commitment or intention to fund that in FY23 as well. I wanted to talk about there's a large population of these dementia patients at our state hospital, and then that can be a huge problem. And there are a large portion of our extreme barriers to discharge list patients. And so very time consuming to find situations for that. We have had some success in implementing pilot programs for this population. That first one was developed in partnership between DBHDS and Mount Rogers CSB, and then Valley Nursing Home in Chilhowie. That's one of the innovative nursing homes. We had a behavioral health unit there was created within the nursing home, and it exclusively serves individuals discharging from state hospitals. And about 60% of those have a diagnosis, primary diagnosis of dementia. They've given us 39 beds, or 40 beds, and 39 individuals, but only one of them has been rehospitalized. So it's been very successful. And then they're actually going to be adding on another 20 beds, so they'll move that to a 60-bed unit. So we'll have another opportunity to move out some folks that we have not been able to discharge back into the community there. And then we're also going to, with them, have a specialty regional older adult interdisciplinary team that will include a dementia specialist. And that team will be able to provide consultation and caregiver support, crisis care, crisis planning, and linkages to other needed services within the community. And so they'll be mobile. And then similar to the Mount Rogers program, Western Tidewater CSB is also in the process of developing a regional older adult team. And they are also working to have 10 beds at the Tidewater Cove assisted living facility, licensed as memory care beds for individuals with dementia. And they'll primarily be used for individuals in crisis and as a respite option, and in order to prevent hospitalization at the state facilities. And we're also in early discussions with Rappahannock area CSB to create a partnership similar to that with Mount Rogers and the Valley Nursing Home to find a nursing home to do another dementia pilot. So that's what we'll be using those additional dollars. So I wanted to share that with you. And then we also got—
Delegate Watts has a question. I'm sorry, Delegate.
I'll ask it before we leave this slide. Thank you.
Delegate Watts.
I'm sorry if I cut into a position, another, I thought you were through with this slide. So since I've been recognized, my question goes back to the top bullet as far as the $45 million in bonuses. Could you share with us the way in which you approached the bonuses? Were they straight percentage across the board, or were they given using any other criteria?
So when we identified, I've talked in the past with you about how we identified where the compensation issue was. We were throwing everything against the wall, but we had not ever, or had not since I've been here or in recent history, had a real compensation survey to see versus the market. And so we were able to get the Mercer data set. And in this April, we identified that we were at or below the 10th percentile for our direct care staffing, which was where we needed to focus because they're with the patients day in and day out. And that's where we focused. But what the bonus represents is if we moved the person's salary from where it was currently to the new rate that should be competitive at, that's what the bonus. So if you did that times 2080, so for a whole year, an employee works 2,080 hours is full time, and our staff are full time, what that number would look like. And then we did it into quarters because we only had so much in our reserve that we could pay for. And I believe that the reason that we were not able to get it put, we had to wait until we could get it put in the base budget to really realign those staff salaries to those new rates because it was really ARPA's one-time funding. And so that's why that commitment by the governor to put it into the base budget so we can actually align our staff's salaries to those appropriate, competitive rates is so important.
Mr. Chairman,
Delegate Watts,
just
go
to
ahead.
clarify, and it was following up on your concern, therefore, as we approach the next biennium budget, this 45 million will have selectively affected the base rate so that we are in fact going to be addressing Mercer recommendations about competitive market.
Yes, ma'am. And it's not just rates. I mean, in that so we actually put in additional money that brings it up to that. I said it was 76.9 million. The difference between that and the 45 million is also the quarter that we're paying for, and it's not just rates, it's also shift differentials. We're that competitive. So it's that as well. So it will definitely be a true improvement.
Thank you.
The last bullet that I was going to share was that we also received ARPA funds for permanent supporting housing in Northern Virginia to assess with bed crisis at the state facilities as well. And so that's, we're already operationalizing that and moving through the processes to identify those. Next slide, please, Josie.
Mr. Chair,
Delegate Price.
I apologize. Can we go back one slide? I just wanted to ask a question. Who's the appropriate entity, Mr. Chair or Director, for us to find out an appropriate number for future planning for that last bullet, the $5 million in ARPA funds that went to permanent supportive housing in Northern Virginia? There are some other areas of the state. And I'm just wondering, especially how does Hampton Roads, how do we get our hands into that? And where do we go to find out what is the number that would be needed for more permanent supportive housing across the Commonwealth?
If I can hit on that real quick, I think that's a bottomless pit. We can pick the number, whatever number we want for permanent supportive housing. In the past, Chairman Howell from the Senate Finance Committee has really driven the train on supportive housing. She's been the primary focus of that, and that may be why that $5 million was directed to Northern Virginia. In the past, also, a lot of the providers who provided permanent supportive housing have been in Northern Virginia. There have been a few in Hampton Roads, and there have been a few in other parts of the state, but a lot of that money, I think, is wound up in Northern Virginia simply because that's where the providers are, and that's where the legislative driver has been for that. But certainly there are other proposals. If you've got providers out there, if you make a proposal, I'm all for it. Have I covered that enough, Commissioner?
I would say it's very effective, very needed service, and so I agree. If you can bring proposals forward, we typically bring proposals forward for that. We also can offer some technical assistance for any of those proposals you might want to bring forward.
The reason why Senator Howell is such a driver of that is that's been proven to be one of the most effective ways to provide a person with long-term stability.
Mm-hmm. It's evidence-based.
Delegate Watts.
And I would just add to that as I saw this evolve, and you recall the stats of last meeting of the very short stay within the Northern Virginia Mental Health Hospital. And with those kind of short stays, you both need the staffing of the Community Services Board to provide services outside the, I'm going to use the word hospital institutional setting, but this is where the supportive housing has to go along with it. So let us hope that as we move forward with these components, that this will in fact be something that needs to be done wherever we're no longer housing them in a hospital.
Delegate Hope.
Thank you, Mr. Chairman. And since we're talking about permanent supportive housing, Commissioner Land, I know that you have a number of people on the extraordinary barriers list, and I don't know how many of those would be benefited by more funding for permanent supportive housing, but that's got to be a good place for you to look to try to reduce your census, and or certainly trying to figure out why those people ready for discharge can't be released into the community, and how can we provide funding to get them served in the community better.
Yes, that's one of our highest priority areas, is looking to be able to directly target that population that is homeless or needs a place that has the supports that are built into it.
Mr. Chairman.
Mr. Chairman,
Delegate Hope.
Do you, Commissioner Land, do you have a number on those that are still on the extraordinary barriers list, ready to be discharged?
We can get that.
It's about
Okay.
350 or something, some number around there. I think Senator Mason had a question.
Mr. Chairman, this Delegate Austin.
Okay, 195 to 210?
Right.
Delegate Austin, I apologize.
Oh, you're fine, Mr. Chairman. Mr. Chairman, I would just like to reiterate what you said at the beginning of the meeting. Our CSBs are so understaffed, and we rely so heavily on our CSBs for the needs of the people in the need of service. So I would just like to reiterate to Commissioner Land, not only the housing, but our staffing in our rural areas for our CSBs is crucial. Thank you, Mr. Chairman.
No, you're hearing from the same people I'm hearing from, Delegate Austin. And I agree with you. Delegate Brewer has a question.
Thank you, Mr. Chair. Commissioner Land, during the special session in 2021, I believe Senator McPike put forward legislation for you to convene a work group with compromise of local CSBs and stakeholders to come up with a plan about discharge planning and processes and recommendations by September 1. Where are we at on receiving that? So that way we might be able to look at that.
We have another meeting next Monday, the final meeting, and it will be shortly thereafter. We had to ask for an extension.
Thank you, Commissioner.
Thank you very much. You can continue, Commissioner.
Okay, so this is the status of contracts with private hospitals. We continue to add to this list, and we're trying to engage every strategy we can. It gives you a snapshot of some of the ways we're contracting, including contracts using new FY21 and 22 diversion and step-down contracts. So we have about 20 new agreements, and we've also contracted with 3 CSBs for 3 assisted living facilities that are serving individuals that are discharging from the state hospitals. And that, of course, is New River Valley, Region 10, and Western Tidewater. We're also working on pilots. Carilion is one, Carilion Clinic, that projected about 172 diversions per year. And they're already since starting in July and August diverted 50 patients. So they're on track to deliver more than the 172 diversions from the state facility hospitalizations. Also, we've started a pilot with Riverside Behavioral Health Center that will divert 218 acute detox patients per year and create a step-down program once they are stabilized. So they'll build in a continuum of care for these substance abuse patients in the Hampton Roads area. I wanted to give you an update on where they're at because this is a newer project or contracted program. So they have submitted their service modifications to our licensing division. They're renovating their inpatient unit and completing the ligature risk mitigation conversion. The IOP and PHP areas are under construction and they are in recruitment for their staffing. We also have contracted with CHKD for ED intervention services for children that will be similar to what we're seeing at Carilion. And they have their capital improvements complete, and they are recruiting. And so we're anticipating to start seeing the benefit from that and the value from that. So we're really hopeful, and we continue to be very interested in expanding contracts with other private providers to divert TDO admissions and also for step-down units to help facilitate appropriate discharges. And that could be for children, adults, or geriatric patients. So we're moving along on that front. Next slide, please. We had been asked, I went ahead and put it in here. We were asked at the HWI subcommittee to get this chart updated. So we have gotten that updated. So you can see this slide shows the total TDOs issued by courts during the last several fiscal years.
Commissioner Land?
Yes.
If I could, going back to Senator Favola's question, I think she's gone this second, but this chart speaks to the hospital crisis. And fiscal year 2017, The private hospitals were taking over 21,000 TDOs, 83%. And the state hospital share was 43, almost 4,400. Now we have 1,500 fewer TDO admissions total. But the private hospitals have gone down about 4,000. That's a 75%, 17,554. And the state share has gone up 1,600, even though we have fewer. And that's the hospital crisis in a nutshell, and also the employment issue, the reason why the hospitals are so dangerous and so overcrowded.
Right. Yes, sir. And then, but you can also see that drop off with the COVID, that first quarter that we had COVID, when it hit, we really saw a reduction. People were staying at home, and you can see that we've had a reduction. It's been it's just not as much activity, but I believe it will begin to go back up. And so that's the other scary thing about this chart.
That is scary. If it goes back up and that bottom, that maroon arrow continues to go up, that means another hospital crisis around the corner.
Mr. Chair.
Delegate Price.
Yes, Mr. Chair, this is the second time we've seen a chart quite like this. But I think one part that might be missing from the conversation is hearing from the dark blue. Is there a chance for us to hear? Because at home, at least, I'm hearing a lot of nuanced conversation with the private providers that I don't know that full conversation happens in front of us. Is it possible for us to get them in front of us as well?
If we can add that to the next agenda, I think.
Thank you.
Delegate Hope.
The thing that I have trouble with this slide is it only tells part of the story. If you talk to people in the hospitals, someone in crisis is not necessarily someone that's there involuntarily. They could become involuntary. And so unless we know what the other side of the ledger is, people coming, we've been spending a lot of time trying to destigmatize mental illness.
Delegate Hope, I hear that argument all the time from hospitals.
Especially in COVID, but they're certainly coming forward and they're getting hospitalized. So this chart only tells us those that are TDOs. It doesn't tell us who come there voluntary. I'd like to know so we can get the total sense of admissions for mental health in our private and public facilities. That will tell us what's happening.
Julie, do you want to?
Good afternoon, Julie Dime, Vice President of Government Advocacy for the Virginia Hospital and Healthcare Association. It's nice to see you all. Yes, we can get you that information. We do have that. We have sent a letter that outlined how many voluntary, which we take nearly 100% of all voluntary, and then we take 77% of all TDOs. I misspoke and said 88% at a recent meeting, but it is 77%.
So you disagree with the 75% number up there for TDOs?
That the private hospitals are
Yeah.
okay. I'll even give you 75%. But it's 70. The last time we did it was 75 to 77.
Do you agree that the private hospital, the roll number has reduced in the last 4 years from over 21,000 to 17,550?
TDOs have been reduced. Yes,
Okay.
TDOs across the board have reduced.
Okay.
Not just at private hospitals, but also at state facilities as well. They've gone down. Voluntary has gone up.
But-
TDOs have gone down.
But the state hospital share has gone up from 4,400 to 5,940 in the last 4 years.
I can't confirm the state hospitals'
Okay.
numbers, but I can certainly I can tell you ours.
Okay,
And I can follow up with that to confirm that.
thank you.
I suspect they would tell you the right numbers. I wouldn't argue with their numbers, but
Okay,
yeah.
thank you.
Yeah, sure, of course.
Okay. So we'll do next slide. And then, so this, next we're going to talk about the crisis system transformation. And currently, our crisis system has multiple disparate ways for people in crisis to access care. And this somewhat of a patchwork of access points is often confusing to the person in need of crisis services and also creates multiple hurdles to accessing help. This has contributed to over-reliance on 911, law enforcement, and high acuity, high cost services such as inpatient hospitalization. We do have significant momentum to address Virginia's longstanding challenges and overutilization of the high acuity, high cost services, and to build an evidence-based continuum of behavioral health care that features high quality services, including comprehensive crisis services and a centralized crisis access line. So the vision is for our future crisis system is to keep Virginians well and thriving in their communities and to meet people's needs in environments where they already seek support, and to provide care in the least restrictive environment, and to optimize taxpayer dollars by investing in crisis prevention, crisis early intervention, and of mental health problems and crises. And we're in the process of working with key partners and stakeholders to transform our crisis system. Next slide, please. You can see on the right side of the slide, there are 4 core elements of the crisis system transformation Virginia's undergoing. And you'll see that there's high-tech crisis call centers. That's someone to call when you're in a crisis. It's 24-hour, 7 days a week, mobile crisis teams, and that's someone to respond to you when you're in crisis. And then crisis receiving centers, and those are somewhere to go, but for you to end up and go to. And they allow, the crisis receiving centers allow for individuals to be drop off by law enforcement or brought in by a family member. They can be by law enforcement or voluntarily or involuntarily. And they have 3 main components that you'll see there. They can be either co-located or in close proximity. But so they have urgent behavioral health care services. They have 23-hour observation beds and are attached to or close to a 16-bed residential crisis stabilization unit. So they can get rapid assessment, intervention services, physical health assessments, medical clearances if they need to go for an inpatient visit. They can get substance use detox services, linkages to other community resources. But that 23-hour observation and the attached crisis residential stabilization unit are key. They also have ongoing bridge clinic type services, so ongoing outpatient services that an individual can continue to receive until they get placed in their long-term services within the community. And if a patient needs to be transferred to an inpatient acute facility, the CRC staff would provide the transportation instead of law enforcement having to come back again. And with our ECO length of 8 hours and our TDO orders lasting 72 hours, this availability of the 23-hour observation framework would likely allow for many additional diversions. It's a level of care that we have not had in Virginia. And that is also some of the you can see on the slide that some of the FY22 investments that made in the different elements of this crisis transformation are there on the right, including the $7 million in supplemental block grant funding for CRCs and $4.2 million for CTAC expansion. And we also have all of the crisis services coming online, all of the rates, the new rates for them through Bravo beginning December 1st. And that's our go live date for our new crisis services. So our call center and the mobile crisis teams to be online. So that's very exciting, and hope that we're going to see good results out of that. That'll bring a lot of value to the system. Next slide, please. Okay, some other investments. We were funded $10 million for FY22 and 23 for ARPA. And that $6.5 million is designated towards the development of the non-law enforcement mobile crisis teams. And that's both across adult and child populations. And we want to be able to expand access and go 24/7. They're designated to the regional hubs, which are the CSBs, with the intent for the CSBs to operate or subcontract for the services. And then we also have $3.5 million in crisis receiving center support, and that availability of short-term acute therapeutic options, such as that 23-hour observation beds to divert from hospitalization, is really going to be key, we think. We've also worked, again, with Medicaid, with DMAS, to get these services built out. And so, again, they're going to come online in December. Next slide, please.
Mr. Chairman.
Senator Mason.
Thank you, Mr. Chairman. Commissioner, this is kind of a mixture of the last two slides question. So, in the meeting of the last commission, we asked to, close to fully fund the October report from the previous year to bolster CTACs that were ready to go. In the last slide, you show call center staff, mobile crisis, more money than to the crisis receiving centers. I understand we're standing up programs, but the three main components on the left side, it seems that we have facilities, at least some, that are ready to go now. This slide says, and you said you'd presented this previously, so maybe we're well into the 2 or 3 months period, but where are we in the 2 or 3 month period as far as identifying mobile crisis receiving centers that are ready to expand and getting as much money to them to do so as possible immediately?
So we have we're in an RFP process. And so folks are submitting for those, and then we'll move forward with it. Some of the CTACs are already identified. Some may want to do all three of the pieces. So the CTAC, the 23-hour observation, and the crisis stabilization. But it may be that it's in an area that doesn't need that level. So we can have a CRC light version. So we're receiving the proposals.
Mr. Chairman, one more.
Yes, sir.
So that's great. So we're in the middle of RFP process on some of them. Some are already identified. Is that money going out the door today? Or, I mean, this seems like the most immediate way that we can impact the crisis in the hospitals. And to Delegate Austin's point and Senator Deed's point previously, the enormous crisis that we're not spending a lot of time talking about with our CSBs on the ground, not just in discharge, but in receiving these folks. So this seems like the way that we can make the biggest impact the quickest manner. And are we doing that? Because 2 to 3 months seems like a lifetime.
So I think that one of the things that we have to do is there's a process where the money actually gets to us, but we are doing the RFP process and identifying everything while that process goes on.
Mr. Chair,
Thank you, Mr. Chair.
Senator, or Delegate Brewer, I apologize.
don't send me there. Mr. Chair, question for Commissioner Land. So I see that we're already in the midst of this RFP process. Where is that even located, and how are you informing people about this grant process, and how far along are you?
I could tell you the ones that we are working with, that the funding is basically going out the door almost immediately. It's Highland Community Services, Mount Rogers Community Services, Prince William County, Region 2 through Prince William County as the fiscal agent. And, the RBHA is doing it's for personnel expenses, renovations, furnishings for the new crisis receiving center. They're doing a light version. Hampton Newport News, they're doing a new crisis receiving facility. Western Tidewater is doing a light version. Let's see, Region 2 was a full CRC. Prince William was a CRC. Mount Rogers, a CRC light, and Highlands, a CRC light. So that's the proposals that we have that are the ones that will be funded immediately.
Follow-up question, Mr. Chair.
Delegate Brewer.
Thank you. Commissioner Land, so what I'm hearing is that you have a lot of things in process. You have a RFP process in place, but you have data, I would imagine, I'm certain you do, that you're seeing where, there are pockets of crisis all across Virginia. So are you grading this RFP process to ensure that the communities that need this the most are getting it first, rather than having who applies for the RFP? Are you encouraging those communities, especially that are seeing the highest level of crisis system issues up front?
So I will say yes, but also there will be another phase of these that will, because that always is the most critical consideration, is where the need is. But we also will have other phases as more ARPA dollars that are continuing, or budget dollars, or are given to us and funded, whether that's in this next session, or it's in block grant, or wherever it's at, we will be doing next phases so that eventually we get across the system, across all of the Commonwealth, so that it's available everywhere. There's just not enough funding to do it everywhere all at once.
Does that complete your questions, Delegate Brewer?
Yes, thank you, Mr. Chair.
Mr. Chairman, just
Senator Favola.
thank you. Commissioner, one of the things we have heard sort of repeatedly is the crisis receiving centers sometimes do not have the capacity to really provide a venue for the coordinated care that their patients need. Some patients may need a short stay at in a psychiatric bed, but then they need follow-up care in the community. Some patients will need ongoing case management. Probably every patient would need ongoing case management. So when, in fact, you develop the RFP and you're prepared to issue these grants, are you expecting a coordinated care element to the crises receiving centers who will be the recipients of this grant?
So I will say yes, they are going to be a bridge clinic and offer ongoing supports until they get the folks into their long-term, wherever that is, whether it's therapy or medication management or whatever they need ongoing, they will continue to provide services until that's put in place.
That would be very good news. I'm not sure that's truly going on in all of the crises receiving centers. So with all due respect, Mr. Chairman, I think we really do need to work on that coordinated care element.
So I think that one of the things is that right now we have CTACs. We don't necessarily have crisis receiving centers now. And so what we're doing is building out that comprehensive model, which will actually include those things, because that is recognized as a need and something that's lacking currently. So this is to not only be a receiving facility, but to offer, they don't have to go to the emergency department. They will have nursing staff and medical, staff, so that that medical issues or medical clearances can be done as well. So law enforcement can do a drop off. They don't need to go to the ED. They offer 23-hour observation, as well as subacute residential through the crisis stabilization unit, and ongoing outpatient services and medication management until they can get in where they need to go. So it's a full comprehensive model that we're trying to get to.
Mr. Chairman, I think that is the right approach. I hope we get there. The receiving center label doesn't do it for me, but it's okay. Maybe you can come up with a better word, receiving and collaborative care center or something. I don't know.
Mr. Chairman.
Senator Mason. Apologize.
In response to Delegate Brewer's question, the commissioner just ticked off a variety of facilities that have made requests, where they stand, what they're going to do, where they are in the process. Could we ask her to please provide that to all of us as soon as possible?
I think that would be very informative if you could do that, Commissioner. If you could provide us with a list of people that have made our area CSBs that have made RFPs and have plans for this program.
Of course.
Thank you, ma'am.
Okay, I think we were moving into the substance use disorder services.
Yes, ma'am.
Which the pandemic and its resulting impact has, we're expected to see substantial increases in behavioral health needs for many years to come. And we've seen increased alcohol and substance use, including increased overdose rates, which are key concerns, as well as the COVID impact already evident in Virginia. So we're already seeing the evidence of this. We've recently passed legislation regarding marijuana legalization, as well as gambling and casino regulations. So there are additional environmental changes that must be considered when planning for substance use prevention, treatment, and recovery supports for Virginians. Our national overdose rates have spiked, and they were observed in Virginia as well. So specifically, the preliminary Virginia data indicates an increase of 47% in fatal opioid-related overdoses as compared to 2019. And looking at all drug deaths, 60% growth from 2019 to 2020 was observed. We also have experienced significant increases in non-fatal overdose visits to the ER, and they've been observed in every region and every age group from 2019 to 2020. Concerning data, census this shows how pandemic-related impacts outweighed the federal funding through the state opioid response grant, and we fear that these behavioral health impacts will be with us long after the pandemic is declared over. So it's critical for us to continue monitoring this, and it's clear we need more advanced data collection, additional access for this population to naloxone, and increased prevention, treatment, and recovery options, not just for adults, but for children, adolescents, and families as well. So let's talk a little bit, next slide, about the ARPA and supplemental block grant funds. So you did make critical investments during the special session to support and sustain a comprehensive substance use disorder system. And for the ARPA funds, this investment included $5 million in 22-23 to expand community-based substance use treatment services, with the intention to continue with $5 million into FY23 through 24. And these funds will support critical gaps and unmet needs in the community, including treatment of alcohol, opioids, and other substances, and populations outside of current funding streams and available state dollars. ARPA funds also included $10 million to make grants to members of the Virginia Association of Recovery Residents for recovery support services. And there are currently 21 of these accredited recovery residences in Virginia, and this funding is going to really help to expand this much needed community-based resource. And then next, the supplemental block grants there, funds, that's both through the Consolidated Appropriations Act and the American Rescue Plan, are one-time in nature, and they will support prevention, treatment, and recovery, so expansion of those services. This is my last slide, and I know we've been asking questions, but if you have any other questions, I'm happy to answer them, and thank you again for inviting me.
Ma'am, I just want to ask you about the members of the Virginia Association of Recovery Residences. Are those members concentrated in any single part of the state, or are they all over?
I'm not sure I know the answer to that, but we can get that.
Because substance abuse is a problem that affects lots of
Right.
different parts of Virginia.
Right.
Thank you.
We can get that for you too. I'm sure it's statewide, but I don't know if there's different concentrations in different regions for the 21, but we can find out show you exactly where they are.
Thank you, ma'am. Does anybody else have any questions? Well, I think you're free, Commissioner Land. I really appreciate your helping us out today.
Thanks, Chairman Deeds.
Okay, next on our agenda, and I apologize for being a little late. I had an obligation this morning in another part of the state, and I had to run like crazy to get here, even late. We've been talking about the transition from a joint subcommittee to a commission. And so, but we couldn't figure out a time to schedule a meeting of the executive committee. So I had drafts of a work plan and the hiring of a executive director, the job description sent around. Sarah, is there anything you want to talk about this? I had it sent around to the executive committee, and I think there's been consensus in the email that's been sent out. There's been consensus that this is a good way for us to go forward. The idea is for us to have an executive director by the first of the year, and that will significantly change the way this commission operates, I think. Sarah, do you want to?
Yes, Mr. Chair and members. So one of the first orders of business that you need to handle is hiring an executive director. You are currently without staff of your own. And then once you have an executive director in place, that person can help you with setting of work plans and determining how you want to work moving forward. So after discussing with Senator Deeds, what I did is send out to the executive committee to begin with email with a draft of the job description, the job announcement, and a draft hiring plan.
And it's important that everybody know this is description wasn't made out of whole cloth. This was something that you you prepared after you met with executive directors for a number of other legislative commissions.
Yes, Mr. Chair. I had conducted interviews with the executive directors of the other existing independent commissions and talked to them about how they work, the job descriptions for those positions, and the hiring processes. And this draft executive job description, which you have to look at, which is something that I shared with the executive committee and received comments, actually didn't receive any comments on, but had the ability to receive comments on, were there any changes that needed to be made, is what's before you now. This will be, once the final version is adopted, will be made available to the public. This draft job description is an amalgamation of what we see from the other commissions and tracks pretty closely with comparable commissions. It looks at the key responsibilities of the executive director, which would include things like oversight of the BHC staff, which the executive director will get to working with you hire. The BHC is approved for a total of 4 staff. Maintaining communication, developing work plans, things like that. It also includes some of the requirements, the minimum qualifications for the position, looking at things like educational background, work experience, and things like that. Like I said, this will be made available to the public once we have the final version adopted. The second piece was the job ad, which obviously will be made available to all of the public as soon as we're ready to post that, and includes the process for submitting application materials. The third piece I wanted to talk to you about briefly was your plan for hiring. What we had arrived at in our discussion, the executive committee has approved, is a process whereby the job announcement will be placed on the Virginia Jobs website. For your information, that website, information on that website is picked up by other groups like Indeed, LinkedIn, and others, so that would be a broader distribution of the advertisement. Application materials could be submitted to the DLS Human Resources Office as a central point of collecting those materials. DLS Human Resources personnel will then review the applications for completeness. Any application that includes all of the materials that were specified in the ad would be forwarded to the executive committee for review. We talked about having a phone screen process, and the executive committee would receive that information as well. Then the executive committee would be charged with selecting candidates for the first round of interviews and conducting those interviews. We included an option for a second round of interviews should that be necessary. And a key part of this process is that the full Behavioral Health Commission would need to vote on the selected candidate prior to anything being made public, so that the entire commission has the opportunity to weigh in on that decision. I think at this point what you need to do is, it would be helpful if we could, 1, handle any questions that you may have about these materials, and then 2, if you wanted to vote as a commission to adopt them so that we could begin the process.
Well, thank you. I mean, members of the commission, I don't really see that this commission doing work a lot differently than the joint subcommittee did, but the addition of 4 staff changes the game. It changes the game. In the past, Sarah has more than adequately staffed this commission from Division of Legislative Services, but Sarah's one person. Sometimes we've had 2 or 3 people, but this will give us 4 people that will be dedicated. And the people that we've had have all been, they've done this on the side as part of their legislative services duties. These will be 4 people dedicated to this commission's work. So this changes everything for us. It's very important, and that, this description, this process is something I want to make sure that we're right on, because it changes everything. So what kind of questions do you have?
Couple.
Senator Favola.
No problem. Thank you, Mr. Chairman. So the expectation would be is that we would delve deeper into issues and have the manpower to actually report back on studies, convene work groups, convene stakeholder groups, come back with recommendations, somewhat like the Commission on Youth works, where we...
Well, absolutely. I mean, Senator Favola, my concern all along was that this work was bound up with people that are elected, and if they get unelected, the work can kind of disappear or not be as important to the next generation. The staff gives us the ability to have long-term stability and focus and dedication to these issues, and to make sure that
really important.
that we keep the momentum. We recapture the momentum, and we keep it rolling, I think. That's why this process and the executive director position is so important.
I have a question, Mr. Chairman.
Senator Mason.
The minimum qualifications, advanced degree, the first bullet, so that means master's and above?
Yes, so Senator Mason, and that's something that we see across some of the other commissions as well. That would include a master's degree or higher in health policy, public policy. We also include public health law, so it would include somebody with a law degree, something like that.
Okay, well, I did, thank you, Mr. Chairman. The second bullet has a bunch of ors in it. And, I just wondered if you had somebody that had a master's degree in economics versus somebody with a lowly undergraduate degree that worked in the industry for 20 years and was a noted scholar on the topic, but never completed their master's thesis. Are they excluded from consideration?
Well, I think down there it says, or have at least 5 years of experience working within or regularly with the legislative branch on behavioral health issues, or be a behavioral health policy scholar with at least 4 years of experience as a consultant.
Yes, sir, in bullet number 2, but bullet number 1 would seem to be if you have undergraduate degree only, you're out.
Mr. Chair, yes, so Senator Mason, that's exactly what it says. You can change that if you would like to. That is comparable to what we see with the other commissions, but that is exactly how
The other commissions see that, have that. Well, certainly if there's an extraordinary candidate, we can bend the rules, but I don't think, I don't see any, I think the work this commission does is probably more important than the work the other commissions do. I mean, I think we want the most qualified people.
I won't sign on that, Mr. Chairman, but I understand what you're saying.
Okay.
Thank you, sir. I just thought I'd raise it up.
Mr. Chairman,
Senator Hanger.
I guess you could add the word preferred there, so that it wouldn't be exclusive
Okay.
after that advanced degree.
Advanced degree preferred,
Advanced degree in,
preferred in health policy, public policy.
That it wouldn't limit it.
I would be in favor of that amendment.
I don't object to that. I mean, I don't know. I mean,
I'm not sure it makes a whole lot of difference, but it gives you a little wiggle room.
Another possibility is an advanced degree, I'm sorry, Mr. Chairman.
no, go ahead.
An advanced degree or comparable experience in, so that you are then going after the practitioner as opening the door to a practitioner. So I would so move an advanced degree or comparable experience in, and then every.
Mr. Chair, if I might, what we can do if the intent is sort of a two-part question that you actually have to answer here is
Okay.
number one, do you want to include in your minimum qualifications any level of educational achievement? So would you want that to say a bachelor's degree, or do you want to take out the educational requirement altogether from the minimum qualifications? And then depending on how you handle that, we have a following section about preferred qualifications that should you decide you want to treat an advanced degree as a preferred qualification, we can move that to that section of the description. But those are two distinct questions.
I see the preferred qualifications as being independent, because as Senator Mason pointed out, the minimum qualifications start out with an advanced degree. And so when I say or comparable experience, I'm saying comparable to an advanced degree.
How
It's
would
not
you, my only,
comparable
Mr.
experience
Chairman?
in general, it's comparable to an advanced degree.
Sen-
So, no, I don't think that the preferred qualifications flesh.
How do you
are
judge
appropriate.
comparable, though? If you have, if you have an advanced degree or comparable, what would be comparable to a master's
It's a
degree?
Potter Stewart question. I mean,
Yeah, I mean, that's the only hesitation I have with Delegate Watts' suggestion, but I could live with a preferred advanced degree and just leave it at that, and then you don't have to do any comparing, it's sort of open,
Well,
But-
the preferred means that you really open up the door without saying to the selection committee that by opening up the door, you still have to look at someone who's operating at an advanced degree level. And the best I can offer, Senator Frivola, is my own experience where for various reasons, I've just stayed at a bachelor's. And yet there are areas of involvement that I've had with the great depth that I could make the argument that I have comparable experience along with
Sure.
that
So
bachelor's.
I guess we could do both, a preferred degree or a preferred
Yeah, that's-
advanced
that's
degree
what-
or.
that's
That-
what I- yeah.
That would be fine.
Mr.
We'll
Chair-
let
Mr.
staff
Chair-
determine if it's comparable.
Delegate Price.
Okay, so I think that there should be a minimum of an educational expectation. What it is, we can discuss, but that there should be a minimum. And then if it's preferred that it's higher than the minimum, then we can do that. And I think that's what, correct me if I'm wrong, I think that's what Sarah was trying to say. But I do not support taking out a minimum qualification for education, because we're not talking about people that will be helping us. We're talking about someone that's going to be leading us in reforming a very important system that, even just hearing some of the things that we're trying to digest, I do think that minimum should be pretty rigorous for what we're looking for.
And I agree
Mr.
with
Chair?
Delegate Brewer.
I think following up on what I think Delegate Price and probably also Senator Frivola and Delegate Watts are saying, I think we might agree. Maybe the wording is this: instead of saying advanced degree, we're assuming a master's. If we start at maybe the basis of bachelor's, master's preferred, and then we also allow the opportunity for industry-related certifications, I think is maybe the appropriate term. Additional mental health certifications, which are there very many. Because we're saying or a related field, and you're saying other experiences, and I think other experiences is too vague. So what is that and or?
A bachelor's degree in health policy, et cetera, or related field, comma, or a mental health certification in mental health profession or behavioral health related profession or substance abuse related profession.
I guess, Mr. Chairman, how wide do you want to open this? I mean, this is going to be, I have to go back to the comment that was made, I guess, by Delegate Price. This person is going to have to lead the framework for very complicated studies. They'll have to command respect from other professionals. They'll have to have some status and stature to bring the right people to the table, to understand the ins and outs of all the healthcare industry. I don't think it's a high bar, I guess.
But Delegate Watt's point is she could be the executive director of any commission around here and run them all probably as well as anybody.
She is an exception.
And all we're doing is because, as Senator Mason pointed out, this starts out the bullet. You've got to make that hurdle of having an advanced degree. And so this just leaves a little bit of opening if there's an exceptional individual who has, I mean, obviously, I'm assuming that they have at least a bachelor's degree, that they have full 4 years of college. But the or comparable experience is to define advanced degree.
We could live with or, right? Because the minimum would still read an advanced degree in health policy, public policy, health administration, public health, law, global science, or related field, or comparable experience in these above fields.
I don't quite understand. That seems to be moving it away from the strength of your academic requirement, keeping it right, or comparable experience keeps it right.
You want the comparable experience linked to the academic, to the advanced degree?
Yes.
Thanks, Sarah's got it.
The advanced degree aspect of.
Mr. Chair, could I recommend, from what I'm hearing up here, it sounds like what you would want is your minimum qualification would be a bachelor's degree in one of these fields. And then your preferred qualification would be an advanced degree in one of these fields.
Okay.
Is that accurate?
Okay.
I think that's right. That brings clarity.
I second that too.
And that requirement would be, when you look at the minimum qualifications, that requirement for what would now be a bachelor's degree is coupled with the other requirements you'll see there. So that is hand in hand with the second requirement, which would include certain years of experience in specified roles.
Her last point is that a lot of what we're talking about is covered in the preferred because we're talking about years of experience.
Right, 5 or more years.
Are there other questions or other changes that people want to make?
Mr. Chairman, I'm just curious, this is not a,
Senator Favola.
thank you, Mr. Chairman, this is not a change. I guess this would be advertised in
Yes, ma'am.
public health
and that-
journals and,
That plan is, it's at the last page, I think, the announcement
Oh,
we
my
placed
page
on the Virginia Jobs website, and that's with a link on the Behavioral Health Commission website. Jobs posted on the Virginia Jobs website are picked up by various other job platforms like Indeed, LinkedIn, and others as well.
Mr. Chair.
Delegate Price.
Yes, thank you. I see that, try not to laugh, sorry. Minimum qualifications for Microsoft Office and the internet. Are there any other, sorry. Are there any other systems that, in order to really come into this, that we could list under preferred? I'm not sure if it's Google-based or, not trying to give any advertising here, but any systems that the Senate and the House use that we could list there so that there is a expectation that you know how to use more than just the internet.
Ability to competently use the internet. I mean, that's kind of a minimum requirement, yeah.
Yes, sir. I totally understand that as a minimum requirement. Under preferred, I'm wondering if there isn't a higher level of expectation for technological advancement for someone that's going to lead the reformation of a system to a more technologically friendly place.
Mr. Chair.
Delegate Brewer.
I'm inclined to agree with Delegate Price. I think now that we've had, I don't know how many years we're in a pandemic at this point. I don't even know what year it is. But I think that we probably need to really seriously also look at, if we're talking about going forward in the General Assembly, using for commissions or outside of the time that we spend here in the Capitol, utilizing Zoom or Google Meets or whatever preferred tech platform, that at a minimum, we also have to include that. Probably is an expectation as well.
Yeah, well, we've got to remember, we're hiring an executive director, not a technician, not necessarily. That person can hire technicians.
Mr. Chair?
Yes, ma'am.
I'm literally not talking about hardware here. Like, I'm literally talking about the systems that we use to communicate.
Okay.
I just wanted to see if there was something that we could put in, and Sarah, if you come up with something, but something, I need someone that's able to do more than a Google search, sir, and internet is very broad.
I get that.
I think Sarah does have something
As a
for us.
Luddite myself, I resent that, but I get it. Yes, ma'am. Sarah.
Delegate Price, I think, I understand what you're saying. And I think some of this, instead of us listing out programs for concern of missing things, just like we know in drafting, the more specific you are, the more you close off other options. Each of these minimum qualifications is taken in the context of the broader list. So in addition to looking at somebody who can actually use the internet, you are also going to be looking for somebody who does have, say, the analytical skills and the knowledge of research methods to evaluate work, or somebody who has the ability to, there are all manner of statistical software packages that I might be able to tell you the name of, but that's about it. They would need to be able to talk about those things in discussing with you how they meet these other qualifications. We could add language to your specific concern around using Microsoft Office and like communication technologies or something like that.
Mr. Chair,
Price.
if the executive committee is going to be involved in this, I will just take it to the questions of the candidates themselves. So I will withdraw my amendment.
I think that helps. Okay, are there other questions or changes? Delegate Willett.
Thank you, Mr. Chairman. Well, I just want the record to reflect that with those high-level technology requirements, I'm probably precluded from applying for this job now on the internet skill. But on the serious, I may have missed this as a new member. What are the other positions? I'm just trying to judge. We have an executive director, and then what else?
Sarah can probably address that better than I can.
Thank you.
I can explain that. So the current budget language authorizes a staff of 4 total. What you would traditionally be looking at is an executive director and then 2 or 3 analysts who are the individuals that conduct the studies. And then that last position, could be an analyst, it could be somebody to do more administrative work. It depends on what the budget supports. And what we see with these commissions is generally the executive director makes those decisions. The executive director would, of course, communicate with the commission members about how they're doing, but you are hiring an executive director to build the organization that supports the work of the commission. You are hiring an executive director who has the ability to make those decisions, to understand what you want in communication and consultation with the commission, to understand what the commission needs to do the work you want to do, and then build that for you. Generally, what you see with these independent commissions is that the executive director is the link between the staff and the commission. The commission and the analysts may not communicate very often. You may not see them because they're doing the behind-the-scenes work. You are hiring an executive director whom you will trust and authorize and work with to create the machine that does the work. So that's going to be a decision your executive director needs to make, and it will be determined by things like budget and what you talk to your executive director about work plans and this content and the type of work you want them to do. And it is important to think about the type of work you want them to do, because setting up a system where you select 3 studies and the executive director and the staff perform those studies and then come back to you with recommendations at the end is different than, say, the way this commission has worked currently. So you need to think about what you want that work to be as a commission. But those things will drive what the executive director does in terms of creating the engine that does the work.
Thank you.
Are there other questions about any of these documents? Then I probably need a motion to approve this job description as amended and this plan for hiring an executive director.
So moved, Mr. Chairman.
Okay, got a motion and a second. Are there other motions or discussion? If not, all in favor say aye.
Aye.
Any opposed? Okay, the motion passes. Okay, we're on to the public comment section of the meeting. And
Mr. Chairman.
Senator Hanger.
Thank you. Before we leave this topic of getting organized with the executive committee, I just had a couple thoughts that I thought I would express, because I really believe we're at a critical juncture now where this is a very important work for the commission, obviously hiring the executive director, but we also need to make sure that as we're planning the work of this group and for the work of our staff that'll be helping us, that we make it relevant. And the reason for saying that, we have, I don't know, it was several years ago, well, maybe the 2016 session, Delegate Jones and I were involved in budget negotiations, and it came down to looking at where we were at as far as oversight for healthcare in a broad sense. And we looked at, we've got the Joint Commission on Healthcare, which I don't want to offend anybody because some of you are on that or have been on that. But the problem at that point was it was doing lots of good work, but it had become mostly academic, because the decisions that were made were actually being made with the staff of finance and appropriations. There was not a continuity of thought in terms of policy and how you implement that policy. So we started to basically pull the plug on the Joint Commission, which was like $700,000 a year. And, well, no, we're not going to do that. But what we ended up doing was creating a unit in JLARC where we would have somebody that would get the knowledge to give that continuous support to us that we needed, like we're suggesting here. Well, fortunately or unfortunately, we had a great person heading that, and then they were hired by the Joint Commission. So that energy and knowledge has been transferred. We also set up a Joint Commission on Healthcare Oversight to monitor those things. So what I'm suggesting is that all of this work can be for naught and it will cost a lot of money. I'm for looking at the broad system and seeing as we expand this that we retract somewhere else and get focused on what we want to accomplish. That's the point I would make.
It's important that we stay focused on what our job is and
Right, and stay relevant as far as the process.
stay relevant and address it with some urgency. We've always got to be focused on getting this done as quickly and as efficiently as we can. And the executive director, I think, will help us to keep that focus. And I'm hopeful that we will have somebody that's attractive to the Joint Commission on Healthcare.
If I may follow up on Senator
That
Hager's
was-
and express it this way, one of the concerns that I have, given what I've experienced, has it been 6 years now, as a member of the.
Seven, almost.
I'm sorry, I've got the mic on, but I'm ignoring it. All right, we'll try this again. Speaking from the value of the last 6 years that I've been on since the beginning, there was a great deal of interaction with agencies, CSBs, as well as with, I never get all the initials correct. And what concerns me is that, I'll use your word, academic. If we move too much out into just practice issues as opposed to our problems with systemic issues as well as procedures, then that's the relevancy that I am very concerned that we will lose, given that from my broader experience, and I was just sharing with Delegate Price, going all the way back to my very active mentor, Dorothy McDermott, there were those problems back then, as far as the way in which the agency is structured and how a state interfaces with local, et cetera. And that's my great concern, is that we not lose that. And one of the reasons why I think that we had it also was underscored by having the chairman of Appropriations Finance on the commission, as well as the key top members of the Senate side. And so all of these agency heads and various bodies knew to be responsive, that this was important to be responsive. And that's my concern, that we not lose that. And this is why I was very distressed to find that we won't have Sarah continuing, because of that legislative interrelation of what this commission does and what the General Assembly carries out have to stay very integrated so that we are in fact relevant to the delivery of services in Virginia under our current structure, under the structure.
Well said. Does anybody else have anything good for the order? If not, we'll get to public comment. Okay, and the first one that signed up, Bill Elwood, has a PowerPoint. Bill, we generally limit the amount of time people are going to speak in here to like 3 minutes. You can't, I don't know that you can get the PowerPoint done in 3 minutes, can you?
I can talk real fast, but I don't have an advanced degree.
Okay. I'm not sure you can speak to us then.
All right, can you understand me with the mask on?
Yes.
Okay. I'm here with you today as somebody who doesn't know how to use the clicker. As the executive director of the Virginia Coalition of Private Provider Associations, when we get to the next page, you will see who those people are. Go ahead. I'm not going to get into too much of that, but just to tell you that the services that these folks provide run the whole gamut to children and adolescents.
And they're all over Virginia?
All over Virginia, acute, residential, private special education, community-based services, foster care, and adoption. That's who these folks are. Go ahead to the next page. About 2 weeks ago, we had a meeting of the membership, and it was, most of the meeting was a very passionate and urgent conversation that could best be described as Virginia's behavioral health system is broken. You've heard from Commissioner Land earlier. You're very familiar with the issues that they've been having. And we thank her for her efforts. She's been a good partner, and her agency has been very good partners with us as we navigate through this. But we are partners in this effort too, private providers, and we face some of the same roadblocks. Go ahead. One of the biggest things that we're facing right now is the impact of the rates for the services of residential services. They are insufficient to safely serve Virginia children in Virginia facilities. Other surrounding states have been willing to place their children in Virginia at higher rates for less acute. And the examples show you what has been negotiated by some of our providers with the surrounding states. At the bottom there, you see what the Virginia rate is, and that rate was only effective July 1st. 14 of Virginia's 24 psychiatric residential treatment facilities have a certified rate, which means it's been agreed that that's the cost of their doing business, that is higher than what the new ceiling rate is being paid right now. 5 of those facilities are receiving rates below the new rate. One even has, in Senator Mason's district, actually took a rate cut of $100 a day, effective July 1st. Go ahead to the next page. This results in less placement options for Virginia children, and who are then subsequently placed out of state at a rate higher than if they had been put in Virginia facilities. You see a couple of examples there to illustrate this. I found one in the service fee directory, an out-of-state placement that would cost $1,250 a day. So because of this, some of in addition, residential facilities have taken beds completely offline or changed service lines, further reducing the inventory. Next slide. The other issue, and you've heard about this again from the state side, is the workforce shortage. The impact that lower reimbursement rates have on that, but the very critical piece of that is the delays that we're having in getting the mandated background checks for potential employees back to be able to hire these people once we actually do find them. You see all the reasons of why that is. There was changing in the law. They used to be able to be employed, but just not work with children. Now they can't even be employed until their background check clears. So we're finding people who just don't want to wait around. They can go work down the street at Amazon and not have to wait for their weeks to get approved. Next slide. So you can't fill the existing, you cannot staff the existing beds. The beds are there, but the staff is not. And you're asking us to take more and more difficult cases, and we just don't have the staff to do it. Let's skip to the very end, since I'm running out of time here. We need your help. We need adequate rates so that there's more beds in the inventory. It's to ensure a safer environment and better outcomes. And you can see what the critical workforce issues are that need to be addressed, especially, again, in the background checks. But mainly, we need you to listen, because that was the whole purpose of them sending me here to you today.
Yeah.
Don't take my word for it. Go out and visit facilities. They're in your districts, and they need your help. And right now, we're pretty desperate.
And the rates here, North Carolina is $800 a day, Maryland $750, West Virginia is $500, Kentucky is $475, and we are $423.32.
And that's just brand new. It used to be $393.50 until July 1st.
Okay.
And how long, Mr. Chairman?
Mr. Chair.
Senator Mason.
How long was it at $393.50 prior to the change?
Well, it used to be $414. It was cut twice along the way started in 2007. So it had been 11 years since there had been a rate increase. There had been 2 decreases in that 14-year period.
Okay, Delegate Price.
Yes, thank you. Mr. Chair, it would be helpful to know, I guess, bottom line increases that are needed. So when we do talk to our appropriations counterparts, we know what we're asking for. Is that information that that you could get to us, Mr. Elwood, or is that something, where should we go for those numbers?
Certainly, we can give you some good background on that, but they've also go through what is called a cost report with DMAS to help certify these rates. The last one was done, it's based on figures 3 years old that don't account for the pandemic, minimum wage increases. So, there's things certainly that we can do, but some of this stuff is provided through DMAS also. But we're happy to give you more information.
Okay. Well, thank you. Thank you, Bill, very much. Okay, other members of the public that want to speak?
MJ, can I get a time check? It's telling me my time's already expired. I haven't even started talking yet. Good afternoon. My name is Anna Mendez. I am the Executive Director of Partner for Mental Health in Charlottesville. We are advocates for the creation of the best functioning mental health care system in Virginia. We do not speak for consumers, for family members, or for service providers. It is incredibly important to us that you guys have the accurate information that you need to best do your job. To that end, Senator Deeds, in answer to your question about the location of certified recovery residences in Virginia, 16 out of the 22 members of the recovery residences of Virginia are in the city of Richmond, so not spread across the state. Additionally, Delegate Price and Delegate Hope asked about housing issues and how those impact our extraordinary barriers to discharge list. As of March, which is the most recent data I have easy access to, 93 out of the 219 people on the extraordinary barriers to discharge list, yes, my eyes got big too, Delegate Price, were there because of housing issues, either inability to access permanent supportive housing promptly or inability to get into an assisted living facility promptly. So that's 42%. And that's been pretty stable over the last 10 years that I've been paying attention to such things. We are grateful for the investment of ARPA dollars, and we also hope that you will keep in mind that those ARPA funds are one-time funds, and that this is not a problem that has a one-time solution. Senator Deeds, you mentioned that we have a system, right? And very few people in Virginia with mental illness are ever going to be in a state hospital. Very, very few of them, yet they are the population of people that we talk the most about. Right. So I'm very grateful for you bringing us back to the fact that we are, in fact, supposed to have a system. Right now in Charlottesville, the starting salary at our CSB for a master's level clinician is $40,000 a year. And as a result, we have so few clinicians working for our CSB that we have closed our women's substance use disorder treatment center. It has been unstaffed because of workforce issues since the pandemic, and they have actually stopped recruiting. They have given up recruiting. They have decided it's not a solvable solution right now. And when our system doesn't work, it is members of the residents of the Commonwealth that are suffering. So my time is now actually, in fact, running out. So thank you very much for your attention, and thank you for your continued work on these issues.
One thing that concerns me is that we do have a system, but the department treats the CSBs as independent as they are. And what that ends up meaning is that they don't have a collective voice. Right. And so that's where we come in. We have to figure a way to provide more funding to the CSBs. We've got to, in my view, double our investment in community mental health.
And Mr. Chairman?
Senator Favola.
To that point, the CSBs, better than other providers, if you will, do a good job in case management. So if you could be part of collaboratives that bring together providers and hospitals and other systems of support in the community, that would be great, because it's very challenging. Hospitals have discharge planners, but we don't do great case management. No offense to the Virginia Health and Hospital Association. In doctors' offices and other, they're not equipped. That's not they don't do case management, and CSBs are connected to a range of other services, housing, food banks. So that, to your point, yes, it would be great if we could get them funded.
Thank you very much.
Absolutely, and thank you.
Yes, ma'am.
Good afternoon, Chairman Deeds and Behavioral Health Commission members. My name is Jennifer Spangler. I live well with bipolar disorder and advocate on behalf of myself. Since there are new members here from SJ47, I would just like to spend some time introducing myself. I first came to the GA in 2015 so that my daughter would have a positive way to describe me when she encountered stigma from her peers. I was compelled by proposed legislation that would make my involuntary commitment available to police officers. I feared police would mistake my nervous behavior as dangerous at a traffic stop, pull me out of my car, and handcuff me with my daughter watching from the back seat. Since that time, I discovered the need to help policymakers understand the behavioral health system as we experience it. I would like to share with you stories like how an inpatient psychiatrist refused to believe that I was off medication under the direction of my outpatient psychiatrist for the purpose of pregnancy. He assessed me as non-compliant. Because of his incompetence and the law that passed in 2015, I am now in a database. Law enforcement is not supposed to look, I was told, but I'm there. I share my healthcare stories and lobby bills because I believe you can't know how the laws impact us personally without hearing from us directly. The inpatient doctor I mentioned before released me on a new cocktail instead of the one that had kept me stable for the previous 5 years. I believe he worked at the facility where Cho was seen. While hospitalized at St. Albans in Radford, following the Virginia Tech shooting, I had to wonder if Cho had the same inpatient doctor. If so, I could see why he didn't seek help. It was hard to fold the shooting into my world when the victim I identified with the most was the shooter. It took a long time for me to know the decades of scientific research that people who experience mental health crisis are no more likely to be violent than the general public. In this behavioral health crisis in Virginia, please don't create policy for the 3% like Cho that are violent. Choose policy solutions that protects the 97% of us that are more likely victims of loss and of dignity and respect, neglect, abuse, and violence. In crisis, I don't need a hospital bed. I need a doctor that can give me medicine to help me sleep, preferably in my own bed. I need to be at home with the comfort of my regular routine to recover so my spouse doesn't have to take leave to care for me or my daughter. I need a medical home to prevent crisis. I need consistent health care, affordable housing, paid leave to go to doctor's appointments, and a paycheck that allows me to eat and afford medication and providers. We are in crisis, but I implore you to request and find solutions and fund community solutions to solve it. Thank you.
Thank you, ma'am. Is there anybody else? Yes, ma'am.
Mr. Chair, we do have people online.
Online, too. Well, we've got one more person here. We can just let her speak if you care to, ma'am, if you care to speak, now's your chance. Okay. Then we'll go to online. Ma'am, if you're not ready, we can just
Yeah, I just got here, so can I come back after the people online?
Okay, that's fine.
Thank you.
That's fine. We'll just take the people online. I apologize.
Mr. Chair, I would just like to ask anyone virtually if they would like to speak to raise their hand, and I will bring them into the room. Currently, we have Jennifer Faison, who I'm bringing into the room right now. Jennifer, you can unmute and go ahead.
Mr. Chairman, members of the committee, Jennifer Faison, Executive Director of the Virginia Association of Community Services Boards. And I feel like in some ways, my work has been done for me this afternoon, just listening to the comments of folks who are on the Behavioral Health Commission regarding the necessary focus on community services boards as part of the entire system. of behavioral health, a public behavioral health service delivery, as well as developmental disability service delivery in the Commonwealth. And so I really appreciate your remarks, and I feel like we've really gotten to the bottom of some pointed questions this afternoon, and really are upping our commitment to community services in a way that I'm hopeful will play itself out in the 2022 General Assembly session. I did want to touch on a couple of things. First of all, I sent it to Sarah, however, recognizing that you all are on the hunt for an executive director, figuring that she would still be kind of the point person. The list of draft BACSB priorities for the upcoming session. And in that, you all will see funding requests to address our workforce crisis, as well as continuing STEP Virginia funding, funding for the waiver provider rebates for reimbursement rates, funding for Priority 1 for DD waiver services, and then some funding for permanent supportive housing. And that brings me to my next point, which is a couple of you kind of honed in on the $5 million in ARPA funds for permanent supportive housing in Northern Virginia. Our request would be for funding for those other regions that did not receive it through ARPA. And then just as an aside for that, there is a permanent supportive housing report that you all receive each year, and the most recent one indicates that there is a need for about 5,000 permanent supportive housing slots in Virginia, and we're currently standing somewhere just south of 2,500 slots. So we have come a long way, and we still have a long way to go, and it is very important as a census reduction tool. And then the other thing that I would like to say is that with permanent supportive housing, it's important to keep in mind that we cannot just focus on discharges from the state hospital, because those are the exact kind of community-based resources that keep people out of the hospital in the first place. So ensuring that there is that mix available for those slots is going to be important as well. I wish you all the best in finding a qualified and amazing executive director to assist you all with your work. I know that it's hard, and I know that you all have difficult decisions to make, and look forward to continuing to working with you and the new executive director and staff as soon as they come online. Thank you.
Okay, thank you. Yes, who's next?
If there is anyone else who would like to speak, if you could raise your hand virtually, and I'll bring you into the room. Mr. Chair, there are no other hands.
Okay, ma'am, would you like to speak?
Good afternoon, committee members and others. My name is Sharita Martin. I've been here a few times before, and today I'm very ill, but I know that I had to come out here today to share this with you all. It's something I don't want to have to show, but I have no other choice. That was just a touch of my son, Tony Martin. You might remember his name. When what I feel like he could have killed me that day. That was last Wednesday. This was about 6 weeks after he had gotten out of Centera General Hospital. He had been put in there twice. The first time, there was doctor letters saying that my son needed to be stabilized. He needed to be treated for the addiction that he had from overly prescribed medications. And he needed to get help for his psychosis, in which I feel came from after he took Kratom when the Community Services Board threw his medication away. My son went into Centera. He stayed 3 days on his own accord, even though I pretty much begged the judge and the rest of the hearing panel to keep him. But they let him on his own accord, which they were supposed to go back in 3 days and reassess him. Within the last 4 months, my son's mental state has deteriorated rapidly to where he started walking with hunched up shoulders and kept tapping the side of his head. And in the car, I've taken him to Maryland. I've taken him all over to try to get help for him. In the car, his hands are opening and closing so much, I had to cover them. I explained this to the doctors. I explained that he had taken kratom, which I don't know where Virginia is on kratom, but like a lot of other states, it's banned. And I would hope that Virginia is looking at that, because kratom causes illusions, delusions, hallucinations, seizures, liver damage, among a few of the side effects. And when my son went missing in August 2018, after the fiasco with CSB, he had been taking kratom. And ever since then, he's been in this illusion state. Because to the Norfolk CSB told my son that he can do this on you. You can take care of yourself. You can do this. You can do that. When he clearly couldn't. My son had, he looked at me as a negative person in his life. And the illusion part, I felt that he saw a negative entity, because whenever he would give me a hug or come in my room or my house, he taps and do these kind of ritual things. He has water that he uses all the time and tea. He makes tea with yeast in it, oil, dirt, leaves, rose leaves, and great black tea and green tea, which is very high in caffeine. Because my son was he was put on an antipsychotic that stifled his dopamine levels, and then he was put on a stimulant for his ADD. And so when the stimulant wore off, he would crash, because the Invega Sustainer that he was on, that drug lasts a month in your system. So my son became dependent on that. He also became dependent on Ultram, because one doctor started giving it to him on an off-label basis for anxiety. Now, we know Ultram is for pain. Ultram tramadol is for pain. He went from 30 50-milligram pills until I noticed my son having a problem. He was at 240 50-milligram pills. Now, somewhere along the line from 30 to 240, I would think that doctor would say, okay, well, this is not working for his anxiety. Let me go to a real anxiety medicine. So my son has been caught in this web. He's on the high-functioning side of autism. He graduated from Christopher Newport University. He went to Middle College High School at TCC, where he took college classes and his regular high school classes in the 11th and 12th grade. And he graduated with 39 semester credits. And he was determined, no matter what the doctor told him, don't expect him to go to college. No, my son went to college, and Tony is smart. But the Tony I see now is only a shell of the Tony that I knew. I've been before you guys many a times. And I was made to feel like a lot of people, loved ones, caretakers, mothers, fathers that have loved ones with a mental illness or on the spectrum. Like, my voice doesn't mean anything. Like, you're tired of hearing what I have to say. But when I heard about the subcommittee meeting that was first started, with the unfortunate incident with Senator Dees, I was very hopeful for Virginia, but I haven't seen anything. In fact, tomorrow there's a meeting with the, was it NAMI? Because people are being made to stay in hospitals for longer and longer and longer periods of time before they can get them a hospital bed. This is what happened the second time my son was in a hospital. 2 weeks after he was in there the first time. He was in Centero General emergency room for 2 days. No TV. With him being on the spectrum, he liked to hear sounds. He had nothing to soothe him, dealing with his mental state. But anyway, that's another subject.
Ma'am, how old is your son?
He's 32.
32.
He's 32, and he has no quality of life. He used to drive a car. He lived on campus. You know, he would always say, "Mama, I love you, Mama. I love you, Mama. You need anything, Mama? Can I help you, Mama?" Tomorrow, I have to go and get my scheduled colonoscopy because my mom died of colon cancer. During that time when she was ill, I saw her for only a few days because I had to come back to Norfolk to go to court because I was arrested by Norfolk police officers for trying to save my son and not give him a prescription from the doctor. After the CSB threw his medicine away, the doctor gave him a prescription to help taper him down while I was looking for a treatment center. But I couldn't find a treatment center here in Virginia that treats adults on the spectrum. They mental illness, yes, but adults on the spectrum, nothing. So anyway, the doctor gave us a prescription. My son was acting up because he was really in an addictive state. He wanted money from me to buy Kratom. And I said, no. Stopped at Papa John's. He got upset. He wanted his prescription. I said, no. He threw a bottle and busted all in Papa John's. I called the police. And instead of them saying, "Mr. Martin, do your mother administer your medicine?" They didn't do that. No, they kept us out there for about 3 hours and arrested me on false charges of petty larceny, assault, which never happened, and obstruction of justice. That occurred when 2 officers were holding me on the arm, by the arms, and every time I walk, she pushed me. And there was crumpled cement right there, and about the third or fourth time she pushed me, I fell. So obstruction of justice. There was also in the police body cam that said, I think it's a skin thing. I wasn't sure what that meant until I saw it the second time. A skin thing. Oh, because I'm brown, and you're whatever she was. Okay, but I was arrested. Did not see my mother because I had to come back to some foolishness. But back to this. What you saw was just a snippet. Like I said, my son is dealing with really, really terrible mental illness. He was in Centera the first time. They did absolutely nothing. There was 3 nurses that told me they have seen people that had my sons, that were like my son, was having problems like him, because they had been on Kratom. And so they knew this. The doctors in there, Dr. Campbell, another one, they know about Kratom and the side effects and the lasting side effects. But when my son went there, we had the hearing, and the judge asked the doctor what was being done for my son. She said they were helping him with coping skills. And I said, coping skills for what? Psychosis? I don't know, because he wasn't given anything for psychosis. I have a letter from a psychiatrist, addiction psychiatrist from Northern Virginia that's been in business for 30 years, and he wrote that my son needs to be stabilized. He's dealing with psychosis. He could be a threat to me. I've went to Portsmouth Naval Hospital. I've went to Bethesda, and nobody would help me to get my son to bed. And they say, did he say, ask him the two things, not the four, but two things. Do you want to commit suicide? No. Do you want to hurt somebody? No. But can you take care of yourself? No, my son could not. Do you do things that could put you in danger? Yes, he did. But even though I told them that I didn't feel safe, that was out the door. I requested a meeting with his doctors, never got a call back. When I called the psychiatric department, and I told them, I said, look, I'm not getting any responses. The social worker didn't call back. The doctors didn't call back. The nurse, nobody. So I said, I have no other choice but to take this higher. I'm trying to get help for my son. And so the next day, that night when I went and his godmother, and there was a nurse that knew my son from before, she told me she couldn't talk to me because Tony's he had taken back his release of information. Now, my son wouldn't have done that. Tony was walking around like this, jumping on one foot, jumping on the beds in the hospital, skipping. He did not know to go to anybody and say, take my mother off. I'm his emergency contact. I'm his next of kin. But the mother thing doesn't matter. But he was told that, and that's what he did. Some person in that hospital took advantage of a mentally ill person and got them to take off the only person that he has. And so when we were there that night talking to the nurse, she knew my son from before. And his godmother, my friend, she said, why is this? She is the only person that he has. And so she got Tony to resign it and talk to us. And she was another one that told me about the side effects of kratom from other people they have seen in their behavioral health. So anyway, the next day I went there, they released Tony. They didn't have another assessment of him. They released him. He didn't have any thing planned. He didn't have no doctor's appointment set up. He didn't have make sure he had somewhere to go. He has an apartment, but he had lost his key with what was going on in his head. He had no way of getting his apartment if I wasn't here. And unfortunately, he didn't really know. He wouldn't have known to go to the apartment office, and it was after the working hours, to get a key. So he would have been homeless on the street had I not been here, because he didn't have his phone, nothing. But that's what they did. They did not even communicate with CSB, who's working with me now, I might add. But they didn't even communicate with them. And so my son was let out. 2 weeks later, he's drinking these teas that he's put all of this stuff in that he keeps outside to ferment that has mildew in it, that has an odor that a dog wouldn't even want to smell. And so I called CSB, I called the police, and then the CSB, they took him, they called CSB, then they took him to CSB. Now, I'm going to add something real quick. I know it's getting time, but...
You're 12 minutes past time.
Okay, well, anyway, I'm going to say this. Sorry, Senator Dees.
No, you're not going to be sorry about it.
Yeah, I just thought this is something that people need to hear, because it's not getting any better. It's not getting better. When my son did this after the second time of being in the hospital, which he still wasn't treated for psychosis, but he was at my house. I felt better with him being there. I felt better with him being there than I was scared. But my son went up into my room, which I normally keep closed, got medication. As I attempted to take it from him, because I didn't want him to go and overdose, is when he grabbed my arm, went down as we were going down the stairs, and proceeded to twist it. And had my big door not been open, I really don't think I would be here today. Because only thing I could see is him twisting my arm and the bones popping out. But as he was twisting my arms, he was pulling me into the house and saying, why are you trying to get me? Why are you trying to get me? Like I was somebody else. And this is what I have told these doctors. These doctors who don't care. I don't care what they say. This person is walking hunched up. I researched that. That is a form of severe mental illness, I might add. But this is my life. My son don't have anybody to check on him but me, and I'm too scared to go there. I have been coming here for years. I have been appealing to all
Senator
of you.
Hanger's got a question for you.
Thank you, Mr. Chairman. I think your point, I've listened to everything you said, but I was wondering in follow-up, you mentioned the CSB is helping. Is this the Norfolk CSB? Where are we at?
Norfolk, yes.
Okay, if you could give me or someone the name of a caseworker that we could follow up, I think that might be more helpful.
Yeah, I would do
As
that.
far as
because-
to determine what really they have evaluated and think needs to be done. I guess if you want something done.
But sir, I'm sorry, but Norfolk CSB has caused this.
But can
When
you
they
give us
threw my son's medicine away,
Right.
they put him in a treatment center in Salem, Virginia, and didn't tell me. And I had to go and get him after the doctor did a reassessment. So what happened after that? All through my son's medical records, Mrs. Martin took a patient out of treatment center against medical advice. Mr. Martin was dropped from the substance abuse program because Mrs. Martin at the time took him out against medical advice, which they had no proof. His caseworker said she called twice, but never got a return call. So I posed this question to them. Who did you talk to? When did you talk to this person? Because I have a letter, see attached, from the doctor that did the reassessment and said that it was not the right milieu because he needs somewhere for people on the spectrum.
Thank you.
Well, what I've heard from in the past, from other people, is that the CSBs I've worried that the Department of Behavioral Health has too much on their table. Behavioral health, on one hand, developmental disabilities on the other. And I've heard from other people that the CSBs have problems sometimes dealing with people that have dual diagnosis, people that have autism. And so we need, I think, long-term, structurally, we need to look at whether it makes sense to divide that department.
Mr. Chairman.
Delegate Price.
Yes, first I want to thank you. I know it takes courage every time you speak about your experience, especially with some of it being so new. And I think what we're hearing is you need immediate help with your own personal situation and getting you and your family on a path to wellness, while we're also listening to some of the systemic issues that we're working on that are going to take time, that unfortunately take patience because we are trying to reform a system that honestly has been neglected for quite some time.
Yes, it has.
And so I just want to say thank you. We heard you. I can't speak for any other time that you've spoken, but I hear you today, and I know my colleagues hear you. So I would love to, I guess, Senator Mason and I are here from Hampton Roads. We can work with Senator Hanger and get that immediate situation looked at and see what's going on. But we've heard your concerns from the systemic failures as well.
Okay, well, thank you. And for me, getting my son the help he needs is going to help me. I have my own mental situations but from this. So getting him the help is going to help me. And that's with a lot of families. So I can give you my information. If I can be of any help, research anything for you guys, I would love to do that. So
Okay, thank you, ma'am. Thank you. Is there anybody else from the public? Does anybody else have anything good for the order? If not, we're adjourned. Thank you.